1, 2,
And review 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, when a patient's kidneys are failing, you can literally just watch the urine output drop in the Foley bags,
yeah,
right?
Absolutely. It's right there in front of you.
Exactly. Or like when their lungs are failing, the oxygen saturation alarms go off instantly. But when the brain is failing well, the skull basically hides almost everything.
Right. It really does. You're completely flying blind.
Yeah, you're looking for these tiny indirect clues on the outside to tell you about this, catastrophic storm brewing on the inside.
It is, it's basically the ultimate lockbox problem. I mean, in neurocritical care, you just don't have the luxury of waiting for obvious signs.
Because by the time they're obvious.
Exactly. By the time the signs are obvious, the damage is often completely irreversible.
Which is terrifying.
Yeah.
So, welcome to this deep dive into the nervous system. We are talking directly to you today, the learner, the strong ICU nurse who is, really ready to move beyond just following orders and start thinking like an elite intensivist.
That's the goal. We really want to elevate that clinical reasoning.
Right. So we are tossing out all that low-yield textbook fluff.
Sure.
Our mission today is to aggressively apply the 80-20 rule. We're focusing entirely on the foundational pathophysiology and assessment skills that literally dictate life or death decisions right at the bedside.
And to do that, we really have to change the framework. We're going to look at every single clinical scenario through a very specific intensivist lens.
Okay, lay that out for us. What does that lens look like?
So you always ask yourself 4 things. What is the underlying problem? What is the failing physiology? What is the immediate threat to life? And finally, what is our intervention?
I love that. Problem, failing physiology, immediate threat, intervention.
Right. If you can answer those 4 questions, you can manage the neuro ICU.
Okay, let's just dive right in. Let's start with the most fundamental problem in neuro, which is basically real estate.
Yes, the real estate problem.
Because the skull is this amazing piece of armor, right? But it honestly seems like a massive evolutionary design flaw when things go wrong. Walk us through the physical constraints of that space.
Well, you have to consider the cranial vault as this completely unyielding fixed container. Inside, you only have 3 components. You've got brain tissue, blood, and cerebrospinal fluid, or CSF.
Just those 3 things.
Right. And the brain produces a massive amount of CSF, roughly like 500 milliliters a day.
Wow, half a liter a day, just inside the skull and spine.
Yeah, exactly. It's constantly circulating and being reabsorbed. But because the skull absolutely cannot expand, an increase in the volume of any one of those 3 components means the others, they have to be displaced.
That's the whole volume equals pressure concept, right?
Right, exactly. That is the absolute core of intracranial pressure dynamics. Volume equals pressure.
So the trigger for a crisis is usually something taking up space that just shouldn't be there, like a rapidly expanding mass, an acute hemorrhage, or maybe a blockage causing that CSF to back up.
Yes, exactly. Any of those will trigger it.
I always picture the skull like this overstuffed, rigid, hard-shell suitcase. You throw in an extra pair of boots like a hematoma and you try to force the lid shut.
Right, and the zipper isn't going to stretch for you.
It's just not. The pressure just builds and builds inside.
And that pressure is what forces a physiologic change. See, initially the brain tries to compensate. It'll displace some of that CSF down into the spinal cord, or it squeezes venous blood out of the skull to make room.
Okay, so it buys us a little bit of time.
A little bit, yeah. But those compensatory mechanisms exhaust really quickly. Inside the skull, you have these tough, fibrous folds of dura mater. There's the falx cerebri, separating the hemispheres, and the tentorium cerebelli, separating the upper brain from the lower brainstem.
Right, so they're like internal walls.
Exactly. And as the pressure overwhelms the system, the expanding tissue just smashes into these internal walls.
But the pressure has to go somewhere, right? If the suitcase can't expand and you just keep packing things in, the only exit is that tiny hole at the bottom.
The foramen magnum, yes. When compensation fails, we enter the decompensation phase. The sheer mechanical force pushes the brain tissue downward, just seeking the path of least resistance.
And that's what we call herniation, right?
Right. Central or downward herniation.
Okay, so if the brain gets shoved through that tiny opening at the base of the skull, what exactly is taking the brunt of that crush injury? It's like, what gets hit first?
The brainstem. Specifically, the medulla. And this right here is your immediate threat to life.
Because the medulla controls the really important stuff.
Right. It houses your vital autonomic control centers for respiratory drive and vasomotor tone.
Oh, wow. So breathing and blood pressure.
Exactly. When that tissue is compressed against the bony edge of the foramen magnum, the patient literally loses the mechanical ability to breathe, and they lose the vascular tone to maintain their blood pressure.
So they just completely crash.
It is a rapid catastrophic cascade, yes.
Okay, so as the nurse at the bedside, how do we catch this? I mean, we know the why of herniation now, but how do we spot the subtle deterioration before, the medulla is crushed and the patient codes?
This requires a highly focused assessment. You have to separate the early warnings from the late deadly findings. And your primary window into this mechanical pressure cooker is cranial nerve third.
The oculomotor nerve.
Exactly.
I really want to push on this for a second because, we always check pupils, right? Every neuro check.
Uh-huh.
But I don't think we always think about the physical pathway of that nerve. Why is cranial nerve the third so sensitive to this downward pressure?
It honestly comes down to purely geographic vulnerability.
What do you mean?
Well, cranial nerve third exits the brainstem right at the tentorial notch, that tight, rigid opening we just talked about. So as a mass in the cerebral hemisphere expands and pushes downward, it mechanically pinches cranial nerve the third right against that rigid shelf.
Oh, so it's literally getting crushed against the wall.
Yes, and the structure of the nerve itself is what gives us the clinical clue.
Right, because the fibers that constrict the pupil, they're on the outside of the nerve, aren't they?
Exactly. The parasympathetic fibers, which are responsible for pupillary constriction, they run along the very superficial outer edge of cranial nerve third.
So they're the first casualties.
Right. When the nerve gets pinched, those outer parasympathetic fibers are the very first to be crushed. They lose function almost immediately.
Leaving the sympathetic nervous system completely unopposed.
Yes, which means the pupil dilates and it loses its ability to react to light.
So a sluggish pupil isn't just an eye issue.
Not at all. A newly sluggish, oval, or dilated pupil is a cardinal early sign of central herniation. The mechanical pressure is literally choking off that parasympathetic signal.
Okay, so that pupillary change is our early warning system. That's huge. Let's talk about motor assessment now, because there is a massive trap here for novice nurses.
Oh, absolutely.
Like you walk into the room, you ask the patient to squeeze your fingers, they give you the nice strong grip, and you chart that their motor function is intact. Why is that so dangerous?
Because gross motor strength, like a hand grip, can remain entirely preserved even while significant subtle cortical damage is expanding in the brain.
Wait, really? Even with active damage happening?
Yeah. The grip test relies on deep primitive pathways. If you want to catch early unilateral deficits like worsening edema or vasospasm in just one hemisphere, you must use the pronator drift test.
Okay, we always hear about having the patient hold their arms out like they're holding a pizza box, right? Palms up, eyes closed. But what is that actually testing? And why do we do it for 30 seconds?
So the 30-second window is key because it exhausts the patient's ability to consciously compensate for weakness.
Oh, okay.
You're testing the subtle balance of power in the upper motor neurons. In our arms, our flexor muscles are naturally stronger than our extensors, and our pronators are stronger than our supinators.
So the muscles that turn the hand inward are stronger than the ones that turn it outward.
Exactly. So when there is a mild disruption in the motor cortex, the weaker muscles, the ones keeping the palms up and the arms raised, they give out first.
So the arm drifts downward because the shoulder elevators weaken, and the hand pronates, turns inward because the supinators fail.
You got it. The upper motor neuron lesion effectively unmasks that natural muscle imbalance.
That makes so much sense.
And remember the anatomy, right? The motor pathways decussate or cross over in the brainstem. So a pronator drift in the right arm tells you immediately that there is a developing problem in the left cerebral hemisphere.
That is just such a more elegant assessment than just squeeze my hands.
It really is. It's much more sensitive.
Well, let me ask you the real-world ICU question here. Because, my patient is often sedated, intubated, or completely comatose. I can't ask them to hold a pizza box. I can't ask them to track my finger to test accommodation either.
Right, and in an unconscious patient, you have to adapt. You focus strictly on brainstem reflexes. For the eyes, we look for PRL pupils equal, round, reactive to light, We drop the A.
Because accommodation requires them to follow commands.
Exactly. Accommodation requires a conscious cortical effort to focus on a near object. You can't ask a comatose patient to stare at your pen light as it moves closer to their nose.
Right. But their raw reflexive reaction to light remains.
Yes. That single reflex still tells you if cranial nerve the third is intact or if it's being crushed at the tentorial notch.
Got it. Okay, let's transition here. We've covered the mechanical pressures, the rigid suitcase, the herniation cascade.
Yeah.
But that physical crushing doesn't just pinch nerves, it chokes off the blood supply.
It absolutely does. Perfusion is everything.
Let's look at the plumbing and the electrical grid that's keeping this tissue alive, starting with perfusion.
Well, brain tissue is incredibly metabolically demanding. It stores no oxygen and no glucose. None.
So it needs a constant, uninterrupted supply.
Exactly. The blood supply arrives via the internal carotid arteries anteriorly and the vertebral arteries posteriorly, which feed the brainstem.
And they all converge at the base of the brain in the circle of Willis, right?
Yeah.
I was always taught this is like the ultimate evolutionary backup system, a built-in roundabout.
That's the textbook theory, yeah.
Like if a clot blocks one road, the blood just flows around the circle to keep the brain perfused.
In theory, it is a brilliant failsafe. But here is an essential piece of intensivist knowledge. Up to half of the population has an incomplete circle of Willis.
Wait, half? Are you serious?
Yes, up to 50%.
I've seen patients infarct massive areas of tissue so fast, and I always wondered why their collateral flow didn't save them. Are they just missing the connecting roads?
Right. They completely lack the posterior or anterior communicating arteries. This fundamentally changes their risk profile.
Wow. I had no idea it was that common.
Yeah. If an artery occludes, or if, say, a surgeon clamps a vessel during a procedure, they do not have that natural vascular collateral. Their brain tissue will starve and infarct much faster. You just cannot assume the backup system is online.
Which makes maintaining their mean arterial pressure, their MAP, even more critical, right?
Absolutely vital.
Okay, so that's macro blood flow. What about getting medications across the micro barrier? Because the blood-brain barrier, it completely dictates our pharmacology in the ICU.
It is a formidable fortress. The blood-brain barrier isn't just a physical wall, it is a highly active, regulated interface.
Right. It's not just passive.
No. The endothelial cells of the brain capillaries are fused together by tight junctions, and they are actively supported by astrocytes, these specialized glial cells that just wrap around the vessels.
So why did evolution build this fortress? Just to keep bugs out?
To protect delicate neurons from fluctuations in blood chemistry, circulating toxins, and systemic immune responses. It lets oxygen, carbon dioxide, and glucose pass freely, but it aggressively blocks most other substances based on their chemistry.
Which means if I have a patient with meningitis or, I need to rapidly sedate a combative traumatic brain injury patient, I can't just grab standard floor meds.
Not at all. The chemistry must match the barrier. Lipid-soluble or lipophilic compounds can dissolve through the cell membranes easily. Water-soluble or highly ionized drugs, they bounce right off.
So that's the why behind our drug choices.
Exactly. This is the physiological why behind choosing specific lipid-soluble sedatives like propofol or highly specialized antibiotics that can cross the meninges. If you don't understand the barrier, your intervention literally won't reach the target tissue.
That makes total sense. And that brings us to the autonomic nervous system. The great electrical tug of war regulating all of this, right?
Yeah.
The sympathetic fight or flight versus the parasympathetic rest and digest.
Right. They provide dual opposing innervation to nearly every organ system, maintaining absolute homeostasis.
Geographically, just as a refresher, the sympathetic preganglionic cells live in the thoracolumbar spine using norepinephrine.
Right.
And the parasympathetic system operates out of the brainstem and the sacral spine using acetylcholine. It's a beautifully tuned system when we're young.
When we're young, yes.
But what happens to that electrical grid as a patient ages? Because I see older patients stand up and immediately get dizzy, or their blood pressure just bottoms out during minor position changes. Why is that?
This is a perfect example of failing physiology. As humans age, we don't just lose neurons. We experience a degradation of myelin in the peripheral nervous system.
Myelin being the fatty insulation wrapped around the axon of the nerve.
Yes. That myelin sheath is what allows electrical impulses to travel at lightning speed. When that insulation degrades, the conduction velocity slows down significantly.
Okay, so the signals are delayed.
Right. Now imagine an older patient moving from a supine to a standing position. Gravity immediately pulls their blood volume down into their legs.
And in a young person, the baroreceptors sense that drop in pressure, instantly fire a sympathetic signal, and clamp down on the blood vessels to push blood back up to the brain.
Exactly. But with degraded myelin, that signal is sluggish. The sympathetic nervous system cannot mount a rapid enough vasoconstrictive response.
Oh, I see.
The blood pools, cerebral perfusion drops momentarily, and the patient experiences orthostatic hypotension and dizziness.
It's not just generalized weakness then. It is a literal breakdown of the autonomic conduction speed.
Precisely.
And they also lose the ability to vasoconstrict or sweat efficiently, right? Meaning they are at a much higher risk for hypothermia or hyperthermia in the ICU.
Yes. They lose the microadjustments required to maintain temperature and vascular tone. As an intensivist, you have to anticipate this fragility in their hemodynamics.
Okay, let's tie all of this into a critical scenario. Say we've done our bedside assessment, we caught the subtle pronator drift, but now the patient is getting worse.
Okay.
They have a newly sluggish pupil. We suspect an expanding mass and impending herniation. We need diagnostic proof, and we need it immediately.
In an acute neurological crisis like that, your first diagnostic line is the CT scan without contrast. That's followed by a scan with contrast if a tumor or vascular issue is suspected.
Because an MRI takes, 45 minutes? And the patient has to lay perfectly still.
Right. A CT takes 3 minutes. Immediate threats require immediate diagnostics. If your patient is actively herniating, you do not put them in the isolation of an MRI tube. You get the CT.
And if they're getting contrast for that CT, the priority nursing actions kick in, right? Because the contrast is iodine-based.
Which is highly nephrotoxic, yes.
So we check the BUN and creatinine. You screen for iodine or shellfish allergies. And crucially, if they are a diabetic taking metformin, you must hold the metformin before and for 48 hours after the scan, right? To prevent compounding kidney damage and lactic acidosis.
Those are essential interventions, absolutely. Now let's discuss a procedure that involves a massive clinical trap, the lumbar puncture.
Oh, the LP. Usually a physician inserts a needle into the subarachnoid space at the L3, L4, or L4, L5 level to draw off CSF for analysis.
Right.
And as the nurse, you are positioning the patient's side-lying knees pulled tight to the chest to open those vertebral spaces.
That is the standard preparation, yes, usually for a meningitis workup or to check for subarachnoid blood. But this is the most dangerous, fatal error a nurse can fail to catch.
The ultimate red flag.
You must absolutely never perform a lumbar puncture on a patient with signs of significantly increased intracranial pressure.
So if the patient has a blown pupil, worsening Glasgow Coma Scale, or papilledema on an eye exam, you have to stop the procedure.
You have a duty to stop it.
Explain the physics of why this is so deadly.
Go back to your rigid suitcase analogy. If you have massively high pressure trapped inside the cranial vault, and you suddenly insert a needle into the lower spinal column and drain fluid, you create a sudden extreme pressure gradient.
It's like uncorking a bottle of shaken champagne. All that intense volatile pressure is trapped up top in the skull. The moment you open a vent at the very bottom of the spine, the pressure equalizes violently.
It creates a massive vacuum effect. It will forcefully suck the brainstem straight down through the foramen magnum. You will cause the exact fatal downward herniation you were trying to avoid. The patient will likely exhibit Cushing's triad-so, bradycardia, irregular respirations, widening pulse pressure, and they will code right there on the table.
The physiology is completely unforgiving. You just have to understand the mechanics of the container before you open a valve.
You really do.
All right, we have covered a massive amount of high-yield ground today. Let's boil this down into our intensivist framework. If our listeners remember only 5 things, what are they?
Number 1, the core pathophysiology. The skull is a rigid box. An increase in the volume of tissue, blood, or CSF will relentlessly increase pressure, eventually leading to herniation.
Got it. Number 2, your key assessment finding. A new unilateral lack of tubulary constriction means cranial nerve the third is being crushed at the tentorial notch. It's a blaring alarm for impending central herniation.
Number 3, the most dangerous complication. Downward central herniation through the foramen magnum, which crushes the medulla, destroying the respiratory and vasomotor centers.
Terrifying. Number 4, your priority nursing action. Ditch the hand grip and use the pronator drift test for 30 seconds to catch early, subtle, unilateral cortical deficits.
And number 5, the ultimate procedure trap. Never allow a lumbar puncture on a patient with signs of high intracranial pressure, or you risk creating a fatal pressure vacuum.
Okay, give us the one-sentence clinical picture. The, if you see this, do this.
If you see a patient develop a newly dilated, non-reactive pupil combined with a pronator drift, think expanding mass lesion causing impending central herniation and escalate immediately for a STAT CT scan and neurosurgical intervention.
That is exactly how you look at the black box and connect the problem, the physiology, the threat, and the intervention.
It's how you save a life.
But before we go, I want to look at where this is all heading, because we've spent this whole time talking about defending the brain, about pressure, damage, and stopping nerve death. And for decades, we were taught that neurons were strictly non-mitotic.
Yeah, the prevailing belief was that once a brain cell died, it was gone forever. The adult brain was just incapable of replacing them.
But the source material touches on this massive paradigm shift. Recent research actually proves that neurogenesis is possible from neural stem cells.
It's incredible.
And even more fascinating, those astrocytes we talked about earlier, the ones building the blood-brain barrier, they actually proliferate after a central nervous system injury to help alter the local environment.
They are actively attempting to manage the damage and create a scaffold for repair. They don't just sit there.
Think about what that means for the future of critical care. What if the neuro ICU of tomorrow isn't just a defensive bunker where we try to stop swelling? What if we start administering targeted therapies that, cross that barrier and command the brain to rebuild its own neurons?
It completely changes how we view recovery. The brain is fighting back.
The sick skull might not just be a trap for damaged tissue, it could actually be an incubator for regeneration. It's just something to keep in mind the next time you're shining a pen light, looking for clues in the dark.
Absolutely. It's a very hopeful way to look at it.
Keep pushing your practice, keep asking why behind the physiology, and we will catch you on the next deep dive.